Hello and welcome to Positive Living. This is so exciting. And we're kicking off tonight with Dr. Philippa Kaye, who is the author of The M Word, which is a brilliant guide to the menopause. Doesn't soft soap anything, tells you exactly how it is, doesn't say that fancy products are going to make your life better. It's just everything you need to know. So readable, very understandable. And Dr. Kaye is just great. So hope you enjoy it. So hi, Philippa. Thank you for joining us. Let's just start with the basics. What is menopause?
So I'm really glad you asked, because none of us were taught about it ever. We were taught about the birds and the bees. We were taught a bit about puberty, and that might have come from our mums or our friends in the playground or bits of a GCSE textbook, but none of us were taught about the menopause. And thankfully, that's going to change from this September. It's going to be included in the PHSE curriculum. But that leaves the generation above me, my generation, and the generation below not knowing what it is. So let's start with the basics. The menopause is the medical word for your last period. But just in the same way that puberty took you years and years, and one day you started your periods, the menopause can have a period of time leading up to it. And that's what we call the perimenopause. And you can have symptoms during that time, whether or not your periods are still here. And then one day you have your last period. But we can't say that you've been through the menopause until you have not had a bleed for 1 year. And so it's what we would call a diagnosis of retrospect, that we can't tell until you've passed it.
And some women I notice have like 9, 10 months and then they have a bleed. So that means they have to start all over again with their counting.
Yes, so you have to start from day one of your period, is day one of your cycle as such, and then it's from that point to a year if you did not bleed again. And what's really important is that even if you are somebody that is bleeding sort of every 9, 10 months, once you've been past a year, if you bleed, you have to see the doctor. That's then called a postmenopausal bleed. And that can be due to things like polyps, but it can also be due to womb cancer. So once you've gone through and you have not bled for a year, any bleeding needs to see the doctor.
Okay. And before that, so if you're in your perimenopause, when should you go see the doctor? Should you wait until your menopause itself or go see it before?
So the answer to that is really subjective, and it depends on you. If you are struggling, come find me or your GP. and that will depend on your symptoms. And I see so many women that say, but I've got my periods, how can I have symptoms? But you can, and I can give you treatment, or your doctor can give you treatment whether or not you have your period. So let's just run through some of those symptoms, okay? So I tend to divide them into the physical and the psychological, and then there's the aesthetic as well. So from a physical point of view, the most common one, the one that we heard about because our mums were hanging out of the window or having an argument with our dads over the thermostat, is about hot flushes and sweats, but also things like joint pain, dry skin, itchy skin, feeling exhausted all the time, real fatigue and insomnia. And then some of the psychological symptoms, I can put fatigue and insomnia on that side too, but also depression, low mood, anxiety, irritability, difficulties with memory and concentration, what we would call the menopausal brain fog, loss of libido, and that can also go on the physical side, because who wants to have sex if sex hurts because of vaginal dryness? And so actually these symptoms can be quite all-encompassing, and that's because we have receptors for the hormones estrogen and progesterone all over our bodies, not just in our reproductive systems. Your periods might come more often as opposed to less often, and they might get heavier and heavier and last longer and longer. Some periods rage against the dying of the light, they don't go quietly. So the answer to your question is, if you're struggling, that's the time to go and see your GP. And if that's as simple as I can't sleep anymore, or I'm so irritable and I don't feel like myself, it doesn't matter what your symptom is. If you're thinking I just can't, or it's beginning to affect relationships or work relationships or family life, then it's time to come and see a doctor.
I think a lot of women don't understand how bad it can make you feel. And when I went to the doctor, I was crying in the reception and I was saying to them, but it's just menopause. You know, I don't need to see the doctor in a hurry because it's just menopause. And it was a receptionist who says, sweetheart, you're sitting down here and you're seeing the doctor today. You need to. Yeah.
Well, I'm so glad that she did. But I think in general, we're really kind to our teenagers. We let them sleep late and we let them be grumpy, and we say, well, they're just hormonal teenagers, they'll grow out of it. But as women or as a society, we aren't kind to each other when it comes to the menopause. And it used to sort of be called empty nest syndrome and put down to our apparent immense sadness that our kids are growing up. Well, not all of us have had kids, and some of us will be very glad when they when they go, and some of us not. And actually, but it's not about that. And I think that in a society that has always essentially taught us to be valued by our ability to bear children, and we do live in a patriarchal society, we are not far off the times, only sort of 150 years ago when that was your purpose as a woman. And when that part of our lives are over, and essentially our looks are affected and our skin is affected, and the messages that we still get very clearly are that older women have less value. Now, that is not right, and I don't believe that. But when the deputy governor of the Bank of England a couple of years ago describes the economy as menopausal to mean past its best, it's not surprising that women feel, well, this is just something that I have to put up with. Now, thankfully, he had to give an apology. But actually, I think that this is our mission as women, and I'm so glad to see the movement like yours that says, no, we don't have to put up with it. We're going to live a third of our lives after the menopause. And quite frankly, I don't want to live a third of my life miserable or feeling past my best. I want to be useful and valued and feel good. And we can do that, but we have to talk to each other so that we know when to get help and that help is available.
Talking is a huge thing. That's what I tell people all the time. Talk about it. So when you go to the doctor, I went to the doctor several times with symptoms that I now know were menopausal, and I kept getting prescriptions or blood tests. How does the doctor actually know that you're menopausal? Is there anything we can do to help them?
So the first thing I would do is get informed yourself, be that coming to events like this, be that reading my book, be that going online. Get informed yourself. You know your body like nobody else. And I never have a problem when someone comes in and says, I've printed this off the internet, is it right? Now, sometimes the answer is no, but sometimes that makes me go away and read something and learn about something. And I don't have any problem with that whatsoever. I think that first of all, if you have a GP practice that has more than one doctor in it, ask the receptionist who's got extra qualifications in women's health, because generally one of us will. So if you come to my surgery and you ask me for a joint injection, I can't do those. My colleague down the corridor does. But if you ask him about the menopause, he doesn't know as he knows, but he doesn't know quite as much as someone that has a particular interest in that area. So if there is somebody in your practice that has extra qualifications in women's health, I would go to speak to that person. The National Institute for Clinical Excellence, who are called NICE, who set our guidance in the UK based on the evidence that we have, has been very clear that over the age of 45, if you have symptoms, we do not need to do blood tests for the menopause. And the reason for that is they're a bit rubbish. 1 month, the levels can be sky high that tell me that you are definitely through the menopause. And the next month, your ovaries kick back in and those levels are normal and you're not. So they're not really useful. What is useful is what you tell me, what your symptoms are. And just on that basis, we should be able to treat you. Now, if you come in and you're under 40, I am going to do blood tests because I want to see if there is another cause for your periods going away. Once your periods start and they are regular or whatever your pattern is, if they stop for 6 months or more and you're not pregnant, then you must see the doctor. It can be problems with your thyroid. There can be lots of other causes. But over the age of 45, it's most likely going to be the menopause, and that's what we're going to treat you for.
Are there any typical symptoms that you see all the time? Is there any one thing that women come to you with? Because we do hear about the hot flushes, and it was hot flushes that eventually made me realize that I was going through the menopause.
So I think hot flushes are the commonest symptom of the menopause. When somebody comes to see me with flushes or sweat, I then run through my list of other things And then often it's that point when the penny drops and they go, oh, but I do have that, and I do have that, and I didn't used to have that. And they begin to realize that actually they've had more. And I think that there's an idea that we have to put up with certain things, or that joint pains are normal as you get older, or that a bit of incontinence is normal when you get older. It isn't. If you have urinary incontinence, see your doctor. That your libido goes off and that's normal with age. No, I can do something about that. That sex gets painful and that's okay. No, I can do something about that. So actually there's lots of symptoms that people don't think about going to the doctor for. And sometimes it takes us to ask. Once we start asking, I find the floodgates open, and actually women realize essentially how many symptoms there are. Or it's after we start treatment and they say, oh, but by the way, my joint pains have gone. Or, oh, by the way, I'm not frightened of driving at night anymore, or whatever it is, which can be really both reassuring and really great, really.
And when they come to you, we've all heard the headlines, we've seen them about HRT. What are the factors you consider when you discuss HRT with a patient?
So HRT has had bad press. There's no denying that. And that's on the basis of some studies that were done a long time ago now, sort of 20 years ago now. And we're using different sorts of hormones to the hormones that we use now. And we're in a different cohort of women. So they were in a group of women that had been through their menopause 10 years before they started HRT. Now, I'm often asked, why did doctors change their minds? Why do doctors change their minds? Even, we're talking about corona. 1 month we were saying don't use masks, and now we're saying do. And the answer is the evidence changes. And when we learn and when we research and we find out more, we will change our minds about something. And that doesn't mean that we were wrong or that we were trying to mislead you. It means we didn't know. And when it comes to HRT, there were concerns about breast cancer, about stroke, about blood clots to the legs, which could then travel up to the lungs. So when I talk to women about HRT, the first thing I do is find out what they know or what they've been told. Because if you know nothing, that's one thing, but if you know things which potentially aren't true, then that's a totally different conversation that we're having. And then I explain what it is, which I'm going to do in a second, and I assess whether or not it is safe for them to have. If it is not safe for them to have, we then move on to all the other things that you can have. And even if you can have HRT, I also talk about the other medicines that you can have and that might be suitable for you, because it's your body and it's your choice. And as long as you know the risks versus the benefits, then it's up to you. So in a nutshell, okay, HRT, hormone replacement therapy, does what it says on the tin. It replaces the hormones which decrease after you go through the menopause. And you could almost consider the menopause as a long-term estrogen deficiency state that, if it is untreated, increases your risk of dementia, heart disease, stroke, osteoporosis. If you treat it, those risks go down. But even if I were to take that bit away, for many women, treating it gives them back their lives, their relationships, their sex lives, their work lives, their friendships. And that is a huge benefit. And we have to hold out those benefits on one side of the scale, and then we talk about risk. Now, when it comes to risks, the biggest risk that people are aware of is the risk related to breast cancer. If you are somebody that is allowed to have estrogen-only HRT, so that is somebody without a womb, then there is not an increased risk of breast cancer. Full stop. If you're somebody that has to take combined risk, there is a combined HRT, estrogen and progesterone, then there is a small increased risk. And when I say small, I mean small, comparable to the same risk of breast cancer as if you smoke, as if you drink more than the recommended amount of alcohol per week. And lots of us do that without thinking about it. That risk is far less than the risk of having breast cancer if you have obesity, which is something that lots of us also do. And so when you put it into context for women and they realize that those numbers are small, actually many of them are reassured. The risks of things like blood clots, I can take away by the fact that I can now give you estrogen in a gel or in a patch. And if I deliver estrogen through the skin, I don't put it in your mouth, which means it goes through your gastrointestinal system and your liver tries to get rid of it. And that interacts with other clotting enzymes, and it's all very complicated. And that would increase your risk. But as long as I'm giving you, and that is still small, but it would. And as long as I give you your estrogen through the skin, that risk is negligible. If I give you progesterone along with your estrogen, if you have a womb, there is no increased risk of womb cancer. And so for many women, they then balance the scales. But headline figures, if you are somebody that doesn't have breast cancer, for example, under the age of 50, there is no increased risk of anything in having HRT. So if you have a premature menopause, actually, we really encourage you to have HRT because we are replacing the hormones which would naturally be there. So under the age of 50, no increased risk. Between the ages of 50 and 60, generally, the benefits of starting HRT outweigh the risks. Over the age of 60, the benefits of starting, not continuing, but starting HRT about equal the risks. After the age of 70, the benefits of starting are outweighed by the risks. So the risks are greater if you start over the age of 70. But as long as you're starting within a decade of the menopause, there is no stop point, as long as those benefits still continue to outweigh the risks. So if you suddenly develop breast cancer, and by the way, you're more likely to survive if you develop breast cancer and you're on HRT. If you develop breast cancer, or if you suddenly have terribly high blood pressure, or something else that means that actually those risks outweigh the benefits, then yes, we'll stop it. And that's why we will ask to see you every year for a review. But for many, many women, the benefits outweigh the risks. And for each time, it is your choice. So it's really important that we keep talking about it. But as I said, for many women, actually, it's a bit of a no-brainer.
Will you take it when the time comes?
I absolutely will take it when the time comes if I have symptoms. If I don't have symptoms, then currently the guidance says that even though we know it's great to prevent osteoporosis, that we shouldn't start it unless you have symptoms. But 4 out of 5 women have symptoms, so I'm pretty sure I'm going to end up with them. And I would have no hesitation about doing it, and I would have no hesitation about my daughter doing it. And if that's not a good recommendation, I don't know what is. But if you're somebody that doesn't want to, or can't, there are other things available. And often people say, oh, why has my doctor prescribed me antidepressants? I'm not depressed. Now, if you've gone for depression that started around the time of the perimenopause, then actually HRT is your first line treatment. That's what's recommended, unless you're somebody who's had depression on and off their whole lives. But if you can't have HRT, then an SSRI, which is a type of antidepressant, can be very good for flushes and sweats, as well as mood. So we can treat symptoms related to the menopause with that kind of medicine. We can also treat it with anti-seizure kind of medication, even though you're not having seizures. So we use medications for different things. So don't think I'm anti-HRT, there's nothing for me. There still will be something.
I suffer from restless legs and I take ropinol, which I've been told is an anti-seizure medicine. So we do tend to think, no, that's for this thing, but they can help other things as well.
And when you read the leaflet, you think, oh, my doctor's got it terribly wrong. but actually, we use lots of things and they're licensed for lots of different treatments.
Yeah, nobody's taken those tablets off me. So finally, what are your 3 tips for women going through the menopause? What would help them have a better life, a better menopause?
So number 1, get informed, get empowered, because that's what's going to help you know what is normal for your body and what isn't normal for your body, and then when to get help. Number 2 is keep talking. We have to talk to each other. We might talk to our friends about hot flushes and sweats, but no one's talking about, the fact that it hurts to have sex. And because of that, we're not getting help throughout that. So 1, get informed. 2, get talking. And number 3 would be take action. And that action can be as simple as a lifestyle choice. I'm going to do exercise. It's going to protect my bones and joints. It's going to be good for my mental health. And actually, it helps hot flushes, even though I was worried that I was going to get hot in the first place. That might happen at the beginning, but actually that then settles down. Or if it's I'm going to have less caffeine because that also is going to decrease my hot flushes, or stop smoking, which is going to be the best thing that you could ever do for your health. or it's going to be take HRT or another medication. So get informed and get empowered. Number 2, get talking. And number 3, take action.
Love them all. Thank you so much, Philippa. That was great.
Thank you.